I'd like to thank SAGES and the AAST for the honor of being able to speak to you today about what to do with common bile duct exploration, and that we should probably think about doing these always lap if possible. I have no relevant disclosures for this talk. Now, obviously, we know that choledochal lithiasis is a common issue that we run into either pre, intra, or post cholecystectomy, and we need to understand how to best approach that. And one of our recent studies that we looked at the National Inpatient Hospital Database, and there's still a significant number, and there's a lot of patients admitted to the hospital every year with choledochal lithiasis, over 25 to 30,000 patients every year. Now, we need to think about how to do more common bile duct explorations across the board, because over the last several decades, the rates of the trends in common bile duct exploration, whether it's done laparoscopic or open, has plummeted. There's still, surprisingly, more open common duct explorations being done than laparoscopic, so we definitely need to do more of them regardless. But I think that it should still be done laparoscopically most of the time. The reason for that decline, obviously, has been the rise in ERCP and the convenience to being able to just have our ERCP colleagues take care of this at our convenience. There's lots of pros to that approach, that it's a very successful operation most of the time. However, it's not without its problems. Adding significant procedure time, a second anesthesia, and not an infrequent rate of complication rates, morbidity, and some mortalities. I've heard of horror stories. There was a patient, a young child, who had probably an unnecessary ERCP at the Children's Hospital and died related to ERCP-related bleeding. And so there are these tragic and unnecessary things that happen with ERCP, and so we should be able to do things more surgically, and preferably laparoscopically, because there's actually there's a robust literature supporting laparoscopic common bile duct exploration, even level 1 evidence that laparoscopic common bile duct exploration has very high success rates in good hands, with a similar morbidity and mortality to that of ERCP in a 2-stage approach, shorter length of stay, decreased numbers of procedures, and it's definitely more cost effective. And this data is compelling enough where SAGES last year there was an official publication. I won't read the whole thing, but I'll highlight the last sentence, that at least a transcystic common bile duct exploration laparoscopically is a safe procedure and should be within the realm of most general surgeons, I added that emphasis, who perform cholecystectomy on a frequent routine basis. And those data are really laparoscopic common bile duct exploration versus an ERCP lap combination, either pre or post. What about head-to-head with open? I didn't think that there was going to be much out there, but actually I think there are some data out there to show that laparoscopic common bile duct exploration is superior to the open approach. One is a NISQIP study that was done relatively recently, and even after adjusting the even after risk adjusting it, the open approach had a higher mortality, morbidity, bleeding, return to the operating room, and really the only downside was that there was a higher rate of retained stones after the laparoscopic approach. There could be some selection bias there, but what about a randomized controls trial? This had to be done, could never be done in the United States probably, but a randomized laparoscopic common bile duct versus open trial that was done. Again, in these surgeons' hands, it was comparable, a very high success rate with both, but the morbidity rate was significantly lower in the laparoscopic common bile duct arm. There was also a RAND Corporation, UCLA appropriate method statistical analysis, looking at the different ways of approaching common bile duct stones, and the quote-unquote, the third point, bullet point, was that there was not a single clinical situation where open surgery was appropriate, except if you're already there doing an open cholecystectomy. So why is there maybe perceived barriers? Why is there only 4% rate for common bile duct exploration laparoscopically? Is it too difficult to learn? Is there challenging logistics? And is it not worth it? Is it easier just to give the case up to the GI doc in your ERCP? Actually, I would argue that laparoscopic common bile duct exploration transcystically can be done by anybody who can routinely do laparoscopic cholecystectomy and has the principles of putting a central line in a Seldinger technique. And if you can do that, it's a very straightforward procedure. We need to train more people. We took that upon ourselves at Northwestern. We developed a simulator, a curriculum, and implemented that curriculum and trained all of our senior residents who are on an acute care surgery service, trained all of our acute care surgeons, and the utilization has significantly risen in our institution, and we've shown that you can reduce length of stay and have a improved hospital cost. We've done that course in SAGES here. We've done it. We have a simulator over at the Learning Center. Please stop by. And the rural surgeons particularly are very keen on learning this technique, and the American College of Surgeons Rural Surgeons course has been wildly popular. Other centers have done simulation and found that training residents or surgeons in practice can actually improve adoption of laparoscopic common bile duct exploration. And this whole idea of, well, it's easier, that doesn't make sense, I'm not going to get compensated to add that extra hour of time. Actually, the work RVU rate is significantly higher, about 6 or 7 work RVUs, since we're all slaves to the WRVU now. So in summary, I would suggest that laparoscopic common bile duct exploration, there's good evidence to support that. It's a straightforward algorithm for a transcystic approach. We've demonstrated that increased training can lead to higher adoption and improvement to healthcare costs and patients, and that reimbursement is really not an issue. So I would conclude that I think that in the right hand, in the right hands, in the right situation, with the right patient. So with rare exception, we should probably always do this laparoscopically, or at least attempt to. You can always stop and usually rely on an expert GI colleague to get the stones out that you can't. There's always going to be exceptions to this, but I think we can do most of it laparoscopically. Anybody interested in learning about our course, we're happy to talk to anybody afterwards and to help get this in your skill set. So thank you very much.